welcome everybody to the Life West Leadership Line. Today, I have a very good friend of mine, Dr. Ted Carrick. Ted, are you in Florida right now?
You know, I'm not going to look behind me to check, but I would say yes.
Okay. Well, behind you is a picture, and it looks like it could be the Last Supper or something. I don't know what it is, but it certainly looks. It looks very. It should be in Florence. So you could probably be in Florence right now. But anyways, so everybody knows Ted Carrick. Ted, you're doing such amazing stuff in neurology. You're doing amazing stuff with functional neurology and clinical neurology, and the things that you're doing of course, in Florida and for the chiropractic profession. I know you work out of a multitude of places, whether it's Harvard and Oxford and stuff. Thank you for the work you're doing, because I know you're doing some great stuff in research, and share with us. So let's just start kind of talking about what you've been doing. What are you up to?
You're very kind. Well, you know, at the end of the day or the beginning of the day, my background is as a clinician. That's what I do. And that is really primary. Now, I have different roles in academics. I'm a professor of neurology here at the College of Medicine at the University of Central Florida, and an adjunct professor at Mass General Hospital Institute. And I'm really fortunate to have a little Harry Potter on board as a senior research fellow at the Center for Mental Health Research in Cambridge in the UK. But it all comes down to what we can do with patients. And you know, Ron, that I have a very vibrant rodent lab. I do animal experiments, and the animal experiments that I do are based upon brain function. We have animals that are models for Alzheimer's disease, for Parkinson's disease that I'm investigating now with my team, but we also give animals concussions, and we see what happens to their brain, and we look at different sorts of treatments, and you'll be really excited. And I think that your people in our sort of community will be very excited, because we've developed a manipulation model with rats and mice that we're looking at and seeing what the consequences is with diseased animals with neurodegeneration. Again, Parkinson and Alzheimer's is my primary area right now. And we have some very exciting research that is in progress right now. We also are doing research, doing the things that you and I do with things like wound healing, where we cause a fracture of a bone and we treat the neck, and we do a variety of vestibular things, or head, eye, vestibular motion activities, and there's much promise now.
And it's all, and everything you're doing is neurologically based. So
that's my field. It's hard to look at anything when you're in a field that doesn't apply to your field, though. We can sort of put a neurological twist on anything, whether you like ice cream or broccoli. We can.
But Ted, one of the things. I mean, let's go back a few years, because I saw the interview when Sidney Crosby, right, the NHL hockey player, right, got on the stage and shared that he came back from massive concussions, which they didn't think he'd play again, and you were with him on the stage, right? And someone, I don't know if a doctor said, well, I'm not sure where, there's nothing that shows whatever, that chiropractic. And he said something like, wait a minute, I'm the proof. Ted Carrick, Dr. Carrick, was who got me back on the ice and got me back skating, right? And got him back playing in the NHL, right? So when you look at that, you see the work that, that you do and that chiropractors do, right? And you see the proof is right there with the patient, right? We call that evidence informed, right? It might not be research studied, but it's evidence informed because it has a heavy patient value there, right? I mean, you have to be seeing that kind of stuff every day in the work you're doing and the work that your diplomats are doing.
Well, the one thing is I don't talk about patients.
I know.
That I've seen, for obvious reasons. But having said that, we see professional athletes every day. We see them from virtually every NHL team. We see them from the football. We see them from hockey. We see Olympic athletes sent to us from around the world. We see collegiate athletes. We see our own Olympians. And our clinical experience is very, very vast, such that if you are a celebrity athlete and you hurt your head, there's a very good chance that you will be sent to see us. We don't have a stigma. Our outcomes are as they are, and our referrals are from mainly, from medicine and from other institutions. And it's really exciting to realize that people have tried to duplicate the things that we do in regards to the type of rehabilitation that we do. The only thing that is absolutely certain is that we've got some aspects of our treatment that other people just can't mimic, and that is the adjustments, the manipulations, the correlation of what you would refer to as chiropractic in regards to a series of other things. And that is really the special sauce, or so that's really set us apart, and it's made us very popular. There's no doubt. And if you look at, every year, for instance, I do the concussion lecture for the new draftees and things like that. And I'm chosen to do that not because I have a chiropractic background or not because they like my tie. I'm chosen for that because our outcomes are known by the community to be associated with a very good probability of success.
And is that NFL? Is that NHL?
NHL, yeah. We do just a lot of hockey, but we do a lot of football. And I tell you, like, we've got the ESPN people in that hang out at the clinic. We've got separate entrances for our athletes. And we keep things very, very secure. But we see big name people, but also we don't, we don't promote ourselves and say, look who we're seeing. Everyone knows who we're seeing, and we get good credit for it. Now, when you look at the things that we do, and you talk about evidence-informed or evidence-based, virtually everything we do, there is great evidence. And evidence in healthcare is sort of like a three-legged stool, where we have our literature, and then we have what the patient experiences, and we have the doctor's feelings, and they have to really blend together the quantitative and the qualitative. Well, the things that we do, there is a lot of good evidence for. We do a lot of vestibular rehabilitation, which is sort of central to a chiropractic paradigm because we're looking at movement of the head and the neck and looking at things. We look at different aspects of aerobic exercise, which is certainly something that is central to chiropractors, getting people to get up and be active with their life. But the combinations that we do with the head and neck and eyes has been well researched by a variety of different people. So we'll use things like sustained apophyseal, natural apophyseal glide or snags. And that's something I've done for 41 years, but it has a greater representations in the physiotherapy literature. So there's a whole lot of things that people share that we don't own, for instance, and neither should we. But a chiropractor that is well trained is very well suited. Let me just tell you the reality of it. We train people to deal with sports concussions. It's not an easy thing. You can't learn it in a weekend. And certainly if you're a general practitioner in medicine or in chiropractic or in osteopathy, you're probably not prepared to treat people that have severe brain injuries. That's just the rule of thumb, even though people do. So our courses are very involved, and it takes them a couple of years to be trained at a fellowship level to be able to see the type of patients that are referred to us. Now, what's happened is that we have got a large number of trained people, both in chiropractic and in medicine, that train with us, that know what to do with these patients. Our medical colleagues or scholars learn that they've got to have a chiropractor working on staff with them. Not so much with the chiropractors, because when you look at concussions and people have dizziness, you really can't treat them successfully with any drug, and there's not a surgical approach. So it really is in our paradigm for that type of niche. That's the niche that I live in. So this is not like a one-man show or story. There are people throughout the world that we've trained, and fortunately we attract a large number of chiropractors. Our training is tough. It's the real thing. Do you need to know more to be able to treat the real cases? The answer is absolutely yes, and we know how to do that. So now, if you have somebody that injures their head and they see a chiropractor that is fellowed, this person has no stigma. People, you get some weirdos that'll take a stab at them because they don't like chiropractors or so, but at the end of the day, the results really do show for themselves. So let me just back up and pony on your question about treating people and about the research that we do. Well, when you look at people that are in clinical practice, there's a moral aspect of our clinical practice to, of course, do no harm and to do the things that are good for people. We have something in research that we call Equipoise. And in order to have a study, there must be Equipoise, which means to say that people must get a benefit out of what you're doing, and the benefit must exceed the harm. So if you come to see me and you've injured your head, I cannot morally put you in a control group that doesn't get the treatment that I'm going to give. I can't do that morally. So, and neither can people that are involved in the brain game. We talk about this all of the time. We can do it with animals, but not with humans, because if we find that something quantitatively has been associated with greater outcomes, then we offer that to these patients. And it's really the type of patients I get in, they can't walk very well, they can't see very well, they're dizzy, they can't stand sound, they can't stand light, they have aggressivity if they can get out of bed. And these people you need to do your best for. So to put them in a control group or to compare them to some other inert experience like giving them an orthotic or, we're not going to do that.
And it wouldn't be ethical. I mean,
I don't think so, and neither do people, in my team, which are multidisciplinary. But so what we have to do is realize that the standard RCT, which we'd love to do, it just doesn't apply for many of the things that we do at this point in time with real patients. It's like, your leg, we can save your leg if we do this, or we can do an RCT and not do that and see if we have to cut it off. So, and we're doing that with animals, by the way, with our wound healing. So let's just back up and talk about how we do it. We have to use patients as their controls, their own control, and we have to look at them almost retrospectively because each patient is treated differently, which means to say that if you see me and the guy in the next room plays for a different team and he sees me, or we have someone from the women's national team in hockey and she sees me, there's a very good probability that none of you will get the same treatment. Chiropractors are okay with that. They understand it. So when you don't have people having the same treatment, it's really hard to say, let me look at the treatment that you have for a concussion. The brain is very vibrant, but what you do for one person depends upon not only their genetic makeup, their previous history, other things. Let me just back up for you a little bit and tell you how meaningful this is. We just did a controlled randomized trial with new hockey players, elite hockey players that are going into the NHL, and basically ones that have not had a concussion in over a year. And what we found is when we compared them to non-athletes, we did evoked response potentials where we put sound and we measured different areas of their brain and how that relates to sound. And the information we get gives us a very good footprint of brain activity. Well, guess what? Well, we found that each of the hockey players had different ERPs than all of the other ones. So there was no consistency. But neither is there consistency in the general public. We know that different areas of the brain will respond to different things. That some people have got greater verbal ability, some people have greater cognitive, so that's okay. But what we did find is that if we looked at and put everyone into groups or silos, that there was a marked difference between some functions in the hockey players than with patients or with people that had never played a sport. Now that is really important because it means to say that their brains are different than people that don't play the sport to begin with, which means that you really can't compare them to normal people that haven't played the game. We have to compare them to themselves. We are going to be presenting this at the consensus meeting in Paris. It's big stuff. So what we find is that sometimes an athlete will have greater activity in their brain in a different function than somebody who's not exercised and maybe affrontated or moved their limbs. And then they'll have deficits in other areas.
Right.
Some of these people have underlying ADHD. Some of them have, are on the spectrum. So each of these people are different and they demand different treatment.
Right, but Ted, wouldn't it, from what I'm hearing you say, in my mind, right? I'm not a functional neurologist, but in my mind, it's the word that keeps coming in my head as you're speaking is neuroplasticity, right? Mm-hmm. Because you have these athletes, like you watch a guy like Steph Curry, who's an NBA basketball player right now, who grew up with a father that was in the NBA, and since he was able to walk, he was on an NBA court, and he was around it all the time. You see these athletes, professional athletes whose children are around it, and they're playing at an early age, and their brain gets wired. It's not genetics. I mean, we don't genetically become a figure skater, but they're around it. Their brain starts developing around that, right? They start firing their neurons, kind of what you said. And if we tested these athletes' brains, we're going to see them functioning at a different level, whatever that is. I'm not saying above, it could be off to the side from what a person who doesn't play that sport or, doesn't do it on a regular basis, right? And that's how the brain gets wired. And the cool thing that I see is that it's all about the brain, right? It's just about the brain and the nervous system. And that's what you're accessing. And what kind of gets me a little eared or upset is that someone came to you and said, well, Dr. Carrick, yeah, we understand what you're doing. We watch these people walk out every day, and they're walking into your office with concussions, and then they're leaving, over a period of time doing phenomenal, where they couldn't drive, they couldn't think, they couldn't be in light. Now they can do all that stuff, but you have no clinical proof.
Well, they don't say that to me. I can tell you.
They can't. I mean, how could they, right? How could they?
It's really interesting. I did grand rounds, or when you have somebody come in and they present their stuff. So I just did the grand rounds at Yale University School of Medicine transplant surgery grand rounds. You say, what the heck would you have a chiropractor presenting at Yale surgical grand rounds? Well, what are they going to talk about? Well, it's pretty easy, because if you need a new liver or you need a new kidney, your brain is not working so well. You've got an encephalopathy probably to begin with. So I do a lot of things with patients with brain injuries and encephalopathy, and of course I work with those people. And
they have no idea either. That's the whole thing, right? They
have a pretty good idea, because I get a lot of referrals.
No. What I'm saying is this: someone has a liver transplant, right? But they have no idea there's anything wrong with their brain, because in the other model, they're just looking at the liver, right? And they would never.
They know. I mean, this is a big thing. Whether they have pump head from the cardiac or other people know, because they get depressed. They have. They don't have affect, they get frontal, they become flat. They're sick people. Yeah. And so people know. But what do you do with it? If you give someone a new liver, do they automatically spring up? Well, the liver can be replaced, but we think that you need to do something for that neurocognitive. Yes. And the neurocognitive is such that you're going to do better if you get up and you walk for a half an hour a day. That's going to help you. But if you don't have the drive to walk, if you don't have the affect to walk, it's not going to go. So we do things that are very specifically tailored for that. Much of it has been seen with what other people do, but we do things that other people haven't done. And from what I look at, and you can call it anecdotal, or you can say what other people do, when we see these patients, we get pretty impressive outcomes, but outcomes that we have to measure, like, before and after. But anyways, there's a great interest in what we do, so we get invited for this. One of people on our team, we're very interested. I'll give you an example. Men and women's brains are different. Well, you know that. And, women are generally smarter.
I have 3 daughters and a wife. I just thought mine was different. I thought theirs are normal, right? Mine was different.
There you go. So they have different brains, but also when it comes to concussions, there's more female concussions that are severe than males. Yeah. And we can go into why at a different time. But the key is you have to treat them differently. So there's a big interest. We've not done very well in our almost misogynistic society of science and healthcare to deal with this fact, and we treat women like men and it doesn't work. Well, we've known that for a long period of time, and we have a lot of the national teams that come to see me and come to see my team. And I mean, people from Sweden, from France, from all over the world. And I think you've had your family at our place, so you'll see these people. So one of the things that we've done, and one of my colleagues, Carol Missouri, is one of the deans at Yale Medical School. She's probably the world's expert in genetic bias and differences, and she works with me in our team to develop this paradigm, to understand it better. And we have to understand it better, and we look at outcome research. That's the way that things drive it. And we take it to
and I love that. I love that. Because the proof is in the pudding, right? I mean, it's like, and that's what my grandmother used to say. And you are getting the outcome results. I mean, obviously the results are there. We're seeing that, right? So I am really thrilled about what you're doing and all the things that are happening. And what I love about it is, you are directly, everything you do is directly onto the nervous system, on the brain and nervous system. And not everything, not everything, but a majority. And what you're doing is just phenomenal. So
but we need the RCTs. Yeah. We need good quality research. But let me tell you, good quality research is not that if it's not an RCT, it's not good research. That's nonsense. I'll give you an example. I was invited to be in that first group with the Lancet neurology group in Barcelona, where we looked at antibodies to NMDA receptors. And that gives you a nasty psychosis. You have to treat this with drug. But that information was published as a case series in Lancet, because you can't do an RCT with it. You just can't do it. Right. Many of the things you can't do. But you can't dismiss the work that we're doing if we take a group of individuals and we look at before and after intervention, and we can show a superior outcome when compared to something else. You cannot deny it. It's not an RCT. So when you look at, if you look at Cochrane studies, or if you look at different valuations, we give them a different grade if there has been an RCT. I love them. That's what we'd love to do. But if you can't do that, you got to go down a little bit. And at the very basis is a case study.
The things you are doing are incredible. I mean, really incredible. I'm so happy you're publishing this stuff. I'm so happy that you've got medical doctors going into your coursework, right, doing your functional neurology work, so that they can see, what we know as a profession, also how the nervous system functions, and how there's a different way of healing besides drugs and surgery. And the things that you are doing are just incredible. And for the profession, for the college, for myself, I want to thank you and your institute and all the people who work with you for the work you do. Because it's
fun.
Yeah,
well, you guys are doing some amazing stuff, and
keep doing it. Keep doing it, please. And
it's good. Be humble. We're learn every day, do our best to help people. And it's interesting, we talk about functional neurology. We don't even call it functional neurology. We look at clinical neuroscience, but the world certainly calls it functional neurology.
And it's clinical neurology, or whatever you call it. But thank you, Ted. I appreciate you so much, and know that Life West appreciates you, and I know that you're taking care of lots of people. And I like to say people would want to say you're performing miracles. What you're doing is working with the body and the wonderful potential that's within the body, unleashing that, bringing that out, and allowing them to live great, productive lives. Anywhere from, like you said, concussions to depression to work, and everything in between, and probably on both sides of that. So thank you. For our viewers, Dr. Ted Carrick, you can always reach him. Ted, what's your website?
CarrickInstitute.com will get it.
We'll put it on the bottom. So it's right now, it's on the bottom. My production team will put it on the bottom. So if they have any questions and they want to find out, what you're doing, or what, or what's offered, they can go to the website. Is that right?
Yeah, they can do it. One thing, just because I know we both got to go, but there's a group called Highmark Brain EQ. It's out of Toronto. They're formed by medical people that were very active in that SARS epidemic and things. But it's a virtual care assessment tool that analyzes brain function, and they built it in an app. It's amazing, and it's really cheap for people. And for chiropractors that may not be in their office right now, they can engage with their patients through this app. It's marvelous. I can tell you from disclosure, I'm a non-paid member of the medical advisory board. They picked all these concussion people, so we don't get paid for it. But obviously, I like it. It's a bias, but it's Brain EQ. It's cheap. It's got a bunch of tests on there that allow you to look at neurocognitive testing, balance, visual in an app. So, like at the Sideline, King David, all of these things are in an app. And it allows the chiropractor to speak and look at their patient directly, give them advice. There's many things that you can tell your patients to do to change it. I just had a very high-profile person that couldn't get out of bed with severe dizziness and vomiting, and I was able to have a consult. I got the wife to do certain things. I could find out they had BPPV. I walked her through the repositioning movement, and up you go, the miracle that occurs at a distance.
Yeah,
and
telehealth.
Doctors can do this. They can do it, and they should. The app will really help them.
Good. We'll put that on the bottom. So they've already, I've had that. My producers will put that on the bottom. And thank you. Thank you for all your information. You've got a wealth of knowledge, and just know that we appreciate you so much.
Yeah, you're the best. Thanks.
Okay.